Good evening, ladies and gentlemen. A warm welcome to another episode of Blood, the Life Savior. We have been getting the feedback that this is really much appreciated across length and breadth of the country, across all the hematology centers. And somewhere down the line, everybody looks forward for this interesting webinar. Today is episode 8, and at the outset, we would warmly like to welcome uh, the professors and faculties of B.J. Wadia Hospital for Children, Mumbai. A pictures you spot, uh, and we can see on screen Professor Dr. Mukesh Desai. Warm welcome to you, sir. We can also see Dr. Vijaya Gauri. Warm welcome to you, ma'am. Dr. Akshaya Chogle and Dr. Vaishnavi. Warm welcome to all our presenters. We can see on screen our excellent spinal cord great supporters, Professor Dr. Bizu George, Professor Dr. Joseph Johnson, who has been our course directors and has been guiding us, mentoring us, and coaching us how to take the whole thing forward. As we all know, this is a short and sweet program for which lasts for a period of 1 hour, where we have a lot of interactive session. All this has been possible courtesy our two directors, Professor Dr. Biju George, Professor and Department of Clinical Hematology, CMC Hospital, Vellore, clinical scientist with 17 years in managing hematological disorders, Vice Chair Asia, Africa, Australia Advisory Committee for CIB, MTR. Many publications to Dr. Biju George's credit, close to 300 publications in Scopus Index and peer-reviewed journal, contribution to 6 book chapters. But we all know him especially for developing the fludarabine and cyclophosphamide conditioning protocol for aplastic anemia. Areas of interest are immense, but immense contribution to the field of stem cell transplant and infection management and bone marrow failure disorders. Sir, we are privileged to have you as our program directors. Our second program director is equally contributing, Professor Dr. Joseph Johnson, Professor and Head Department of Clinical Hematology at CMC Hospital, Ludhiana. So these are two eco states, one from north and second pioneering institute from south, and both merging together to provide the best of both the worlds. Many publications to Sir's credit, more than 30 plus international and 38 national publications, contribution to 7 book chapters in textbook of repute, has been key contributor and many award recipients, to mention just a few, established, and his contribution has been immense. He has been an institution creator himself, established clinical hematology and stem cell transplant services at prestigious CMC Ludhiana, mentor, coached many DM students, launched DM program in clinical hematology in 2019. This is the 6th year in running, and also the innovative service like home care and mobile uh, phlebotomy. May I request both our program directors to take it forward from here, sir?
Thank you very much for the introduction, and we welcome all of you to this 8th episode of Blood the Life Savior. We will follow the same format as we did before. Today's topic is termed Hyperactivity Can Be Harmful, and this is being presented from the B.J. Wadia Hospital for Children, and Professor Mukesh Desai, along with his colleagues, Dr. Vijay Gauri, Dr. Akshay, and Dr. Vaishnavi will present. So this presentation will follow the same format of initially the case presentation, followed by discussion, followed by conclusion of the case discussion by Professor Mukesh, and then we will open it up for questions from the audience. Over to you, Dr. Mukesh.
Good evening, everybody. I think this is a wonderful webinar activity, and thank you for allowing us this opportunity to present something different from the usual hematology cases which we come across. I think when we talk about inborn error of immunity or immune deficiencies, we must recognize that immune deficiencies have components in various specialties. So you can have a rheumatologist, the immunologist, you can have an infectious disease specialist, the immunologist, you could have a hematologist who is also an immunologist. So this is cases which will be presented today, which will bridge the gap between the hematologist and immunologist. Now we all know that immune system arises from the hemopoietic system, and when Dr. Biju George or Joseph is transplanting the marrow, is actually shifting or transferring a new immune system to the donor. And I think we must understand more about the immune system so that we can understand that going beyond the immediate diagnosis very often leads you to the underlying condition, what is immune deficiency. So may I request the presenters to start with their presentation so we can learn certain aspects from this cases which they are going to present to us.
Greetings from Vadia Children Hospital. I am Dr. Vaishnavi Iyengar, and I'll be presenting a case where a gain of function is not really all good. So this was a 6-year-old male child born of non-consanguineous marriage who presented first at SGPGI Lucknow with a history of fever and weight loss for a period of 1 month. They also noticed that the child had significant mucosal bleed. He also had cervical node and a pain in abdomen, which had started some 15 days back. On examination, he was found to have marked pallor with gum bleeds. He had a significant cervical node as well as bilateral hepatosplenomegaly. He had a low hemoglobin with low neutrophil count and a low platelet, and DCT was positive. A bone marrow examination was done here as well, which confirmed peripheral destruction of cell lines. And a lymph node biopsy also was done, which was suggestive of a reactive lymph node. There was a transient response to IVIG, and their initial suspicion was that of a malignancy, and therefore he was referred to Tata Memorial Hospital. At Tata, the patient was reviewed, the bone marrow aspirate was repeated. They again confirmed that there were no blasts, and even a flow cytometry of the bone marrow was normal. The biopsy was also normal, and a lymph node biopsy was reviewed, which was previously done at Lucknow, which also was consistent with a reactive node. They also did a PET-CT examination because of the presence of a lymphoproliferation, which showed metabolically active cervical axillary as well as inguinal lymph nodes with an SUV max of 7.4. He was then referred to our hospital being a non-malignant lymphoproliferation. At our hospital, we found that he was short for his age as well as there was some failure to thrive. There was evidence of frank bleed and a marked pallor. He had cervical as well as inguinal lymph nodes, which was significant, and a hepatosplenomegaly, which was mild to moderate. His hemoglobin at our hospital was 6.4 milligrams per grams per deciliter. Neutrophil count was 480, which was low, and severe thrombocytopenia of just 2,000 cells. His DCT was positive again. A peripheral smear examination did not reveal any atypical lymphocytes. CRP was positive, but procalcitonin was negative, which ruled out severe sepsis. Liver enzymes were also normal. Since he had an ongoing fever of almost 1 to 2 months now, we also did a HLH workup, which was also normal, and the coagulation profile was also normal. All the previous cultures as well as cultures at our hospital was negative. And we usually send CMV, EBV PCRs because they are chronic viral infections which can present in a similar way. They were also negative. And ultrasound confirmed what we already knew by clinical examination. So by now, the story had gone on almost for 2 months. So summarizing the history, this was a child who presented with a 2 months onset of probably autoimmune cytopenia, which involved a DCT positive anemia, thrombocytopenia with a bone marrow aspirate consistent with peripheral destruction and neutropenia, what we call as extended Evans syndrome or Evans plus syndrome. He also had non-malignant lymphoproliferation. So I would like to ask Dr. Vijaya, what is her clinical impression at the end of the history?
So when this child came to us in January 2019, when we went back in history, there was some history where mother said that the child had some cervical or axillary lymphadenopathy for some time, and there was few petechial spots. None of them were actually documented. No CTC was done. So this entire process probably was going on for 4 to 6 months before the child actually presented with a epistaxis and then was referred to Tata Memorial Hospital. So with this history and a history of a lymphoproliferation, a DCT positive anemia, we thought that probably we are dealing with something like an ALPS or ALPS-like phenotype. Now, ALPS with a fast-mediated apoptosis can present with hematopoietic autoimmunity. They also have lymphoproliferation, while ALPS-like phenotype can have immune dysregulation, where T regulatory cell defects are usually seen. So this was kept in our mind, but at the same time, in our experience, we have seen that Hodgkin's lymphoma evolves over time. So lymphoma under evolution was also kept, though it was ruled out preliminarily by at Tata Memorial Hospital, but then lymphoma under evolution was still kept in our mind. And we thought, though the EBV was negative, but EBV is a master masquerader. That is our experience. And so we thought probably this is some viral etiology which might manifest over a period of time. So these were the three basic differential diagnosis that was kept at the back of our mind, and we proceeded further.
So we charted the hemoglobin, the platelet count, as well as the neutrophil count of the past 2 months, and we found that the hemoglobin had gone as low as 5.8, and every week there was a decrease of about 1 gram per deciliter of blood. Also, the platelet count was severely reduced, and he also had some neutropenia, which had improved by the time he came to us. He was started on injectable dexamethasone. He was also then later switched to oral steroids, both of which did not improve his condition much. There was clinically worsening bleeds. DCT remained positive. He was given IVIG again because there was a previous response to IVIG, but the response was very ill-sustained. Because we also thought of an ALPS-like disorder, we also sent immunological workup, which consisted of the lymphocyte subset analysis and the immunoglobulins. The lymphocyte subset analysis was grossly normal with reduced B cells and mildly reduced CD4 cells. However, the immunoglobulin report showed hypergammaglobulinemia. The double negative T cell, which is a type of cell which is increased in ALPS disorder, was 2.4%. Now the normal for the normal cutoff is 1.5% of total lymphocytes. So this was high, but usually in ALPS it's much more higher. HLA-DR percentage was 23, which was mildly increased, but it was not very glaringly abnormal. We also did flow cytometry for FOXP3, CTLA4, and CD25 expression. Now, all of these are disorders or their deficiencies are seen in ALPS-like disorders. And therefore, this expression was undertaken, but these were also normal. Whenever we find a patient of autoimmune cytopenia, we also screen them for additional autoimmunity. So we did the thyroid function, which is normal. The HbA1c was done previously, was 4.2%. And ANA by immunofluorescence was repeated by us, which was also negative. So finally, we did send exome sequencing for this child. And that revealed the presence of a heterozygous missense mutation in the gene called STAT3. Now, STAT3, as you all know, is a very well-known etiology for autosomal dominant hyper IgE syndrome, which is actually a loss of function syndrome, and it was described earlier. But what we saw in this patient was different. He didn't have any features of raised IgE. In fact, his IgE was low. If I go back to the previous slide, you can see that the IgE was normal. So there was no hyper IgE. He also did not have other features of hyper IgE syndrome. While there was a new etiology which was described in 2014 called the STAT3 gain of function disorder. Now, gain of function in STAT3 can happen with different mechanisms. There can be a constitutive phosphorylation or increase in the dimerization affinity and increase in binding to DNA, which can all confer a gain of function to STAT3 molecule. So this is just a diagrammatic representation of the STAT3 gene. It has various domains, and our child had a mutation in the transactivation domain. Now, this is the entire list of mutations in loss of function disorder. And as you can see, it is spread throughout the gene, including the transactivation domain. And this is the list of the mutations that are seen in STAT3 gain of function defect patients. And our child had this particular mutation, which is previously described in multiple patients as being one of the common mutations in the transactivation domain, leading to a gain of function in STAT3. I would now like to invite Dr. Vijaya Gauri to explore more about the STAT3 mechanisms.
Yeah, thank you, Vaishnavi. So I came across this paper, which was a commemoration to 30 years of identification of JAK-STAT pathway, and it was a very interesting paper. This timeline highlights various milestones in understanding the JAK-STAT pathway since 1984. If I can go to the next slide, Vaishnavi. So they were unable to identify, this was a time in 1980s when they were unable to identify how a cytokine which binds to the cytokine receptor results in signal transduction and gene transcription. So this was a question, and that is the time when how gene expression is mediated in response to various exogenous signals was a major question. Then there was a discovery of reversible protein phosphorylation by Krebs and Fisher, which led to discovery of STK, serine threonine kinase, as well as TIC. Then there was a reverse PCR-based identification and generation of protein kinase libraries, which resulted in identification of TIC2. As more and more tyrosine kinases got identified, they identified a new protein kinase with dual phase or domains. This was a two-phase structure. Vaishnavi, if you can point out at the JAK structure, there was an amino terminal kinase domain, which was preceded by a regulatory pseudokinase domain. So red one is amino terminal kinase domain, and the yellow one is a pseudokinase domain. And since this was similar to two-phased Roman god Janus, it was called Janus kinase or JAK. Now this was identified, but they didn't know the function of JAK. And so they started calling it just another kinase. So JAK was also called just another kinase. And by 1986, interferon as a reagent was available. And they started identifying interferon-induced genes. So Darnell and Kerr labs identified that the signal transducing agent was present in the cytoplasm, and that would rapidly move to the nucleus and will cause gene transcription on stimulation. So they then identified what is called as STAT. The purified first STATs were STAT1 and STAT2, and this was in early 1990s. So this took almost 12 years plus. Why did they call it STAT? The STAT, or the DNA binding protein, was named so as they got activated and translocated to nucleus in no time. So STAT. So then came the JAK-STAT pathway. So the 4 JAKs and 6 STATs constitute the JAK-STAT pathway. This was very interesting today, so I thought I should include this in the slide. So what happens as in our patient, as IL-6, as it is shown by the circle there, red circle there, when IL-6 binds to the cytokine receptor, there is activation of JAK, and activation of JAK helps in opening up of a space where a STAT can bind and can get phosphorylated. Phosphorylation of STAT causes dimerization of STAT. They have to dimerize and then they translocate to the nucleus and cause gene transcription. So this is a mechanism of JAK-STAT pathway, and we need to realize 90% of the signal transduction activity occurs through JAK-STAT pathway. Only 10% occurs through what we can call as a PI3 kinase pathway or a STK or a MAP kinase pathway. So this is a very important pathway. And this is also a very important pathway for treatment. So there are JAK inhibitors used right, left, and center now. So looking at the pathophysiology of the disease, as Vaishnavi said, so in 2014, this JAK-STAT pathway paper was published in Blood Journal by Dr. Stephen Holland and the team. And the next year, Dr. El Haddad published Too Much May Be Worse Than Not Enough in the Blood Journal. This was in 2015, where we can see that loss of function and gain of function, both are shown. So as Vaishnavi already said, loss of function mutations, which is again an autosomal dominant negative mutation of STAT, results in what is called as an hyper IgE syndrome, where you have an increase in IgE, but it is associated with recurrent infections, which is essentially candidiasis, dermatophytosis, because there is a downregulation of Th17 pathway. Th17 is STAT3 activation is required, STAT3 mediated activation is required for Th17. And if Th17 is downregulated, there is increased dermatophytosis. And there is reduced number of T follicular helper cells, as a result of which they have a lot of infections. And there is both inflammation, hyperinflammation, and reduced inflammation at the same time, resulting in breakdown and pneumatocyte formation in the lungs, resulting in aspergillus infections. So aspergillus here is a colonizer, and they always come with a pneumatocyte and an aspergillus. They, apart from this, they also have non-immune manifestations, which includes something like retention of a primary dentition, scoliosis, repeated fractures. So all that put together, that is a loss of function. In our child, none of this history was present. So our child then fitted into what is called as gain of function. Now, gain of function means STAT is hyperactivated and there is increased IL-6 signaling. So when there is an increased IL-6 signaling, there is increased phosphorylation of STAT3 and there is increased transcription and resulting in what is called as hyperactivity. Now, when there is a hyperactivation of one STAT, there is downregulation of other STATs, as can be seen in the figure that there is a STAT5 downregulation and STAT1 downregulation, and there is also reduced production of T regulatory cells, which is mediated by SOX3. So all that gives rise to what is called as ALPS-like phenotype. Now, can this be what is called as IPEX-like phenotype? This was a male child also, but IPEX is immune dysregulation, enteropathy in a X-linked and hyper IgE, increased IgE in X-linked, which is an X-linked syndrome. But in this child, there was no hyper IgE, there was no enteropathy. So we sort of thought that this may not be IPEX syndrome, and what turned out to be a gain of function STAT3. This figure shows what all can be an immune dysregulatory manifestation of gain of function STAT3. In our child, we just saw hematological manifestation, an extended Evans phenotype. Nothing else came up. But the same mutation at transactivation domain in 3 patients, in one patient, as reported by Flanagan et al., presented with neonatal onset IDDM. In 2 other patients, enteropathy was a manifestation. One was a child, and the other was the father of the same child who had enteropathy for a very, very long time. And our child, except for hematological manifestation, nothing has come up so far.
So we had already seen that there was poor response to steroids, but now with the exome report, it had opened new doors for us. We knew that this was a STAT3 gain of function disorder, and there were already JAK inhibitors which were available in the market. Surprisingly, during the course of the child in the ward, he had started having rising hematocrit. So initially what had started as an autoimmune hemolytic anemia, there was suddenly an increase in hemoglobin that we were seeing. It had reached up to 18 grams per deciliter. At this point in time, from 16 onwards, he had undergone phlebotomy as well. Now, since, as Madam said, this is a IL-6 pathway hyperactivity, we also did the IL-6 level, which was elevated, and he was given tocilizumab, which is a well-known agent which is used in STAT3 gain of function patients. He received 2 doses of tocilizumab 2 weeks apart, and as we can see from this graph, the platelet count had significantly increased. At this point in time, ruxolitinib was just available in the Indian market, but it was very, very expensive. We started him on 0.4 milligram per kg per day of ruxolitinib. And as we can see from here, the green line shows the duration when the child was on ruxolitinib. So at the start of the ruxolitinib therapy, the child had a hemoglobin of 18. While after starting ruxolitinib, the hemoglobin started coming down and there was no requirement for phlebotomy also. Although the hemoglobin had increased, the platelet count as well as the ANC had actually remained very low. So again, the green line shows the duration for which the child was on ruxolitinib. And as we can see from June onwards, he was started on ruxolitinib, which immediately led to a jump in the platelet count as well as the neutrophil count. So later on, however, around 6 months of being on ruxolitinib therapy, which was extremely well tolerated and was extremely good response to this therapy, the child was put on a drug holiday. And after which we can see that again, everything dropped, the platelets dropped, the neutrophil count dropped, and the hemoglobin also started rising. So we've found that in the whole world literature, there is no other child with STAT3 gain of function, which is reported with a polycythemia. And we know that this polycythemia was also STAT3 driven because we saw a response to a JAK inhibitor. So this particular case is already reported in the world literature by us. He had an excellent response not only on the cytopenia and the polycythemia, but also he gained height. As we know from the previous slides, STAT3 gain of function leads to underfunctioning of STAT5B. And STAT5B is a very important molecule for growth hormone functioning. It is downstream of the binding of the growth hormone receptor. And therefore, these children are also short, which we noticed previously in our history. So on ruxolitinib therapy, he also gained 4 centimeters in 8 months. He has been started on other antibacterial, antifungal, and viral prophylaxis along with ruxolitinib, but he has been extremely well controlled on this drug. So currently now the child is on baricitinib because it's a cheaper alternative, especially since the COVID pandemic. It was a boon actually for our children because some of the drugs which were super expensive became cheaper as they were produced in India. And so we shifted him on baricitinib and he has been doing extremely well on it. So in summary, this was a child with who presented with a prolonged history of non-malignant or a benign lymphoproliferation along with autoimmune cytopenia. He later on developed polycythemia, which is the only child in the world that has developed this particular side effect of or this particular phenotype of STAT3 gain of function. And he has responded beautifully to JAK inhibitor, which just tells you that once the inborn error of immunity is picked up, you have various therapeutic avenues which are much more effective when given. Because previously this child was not doing so well on any therapy. He was poorly responsive to steroids. IVIG response was also ill-sustained. And remember that this is a big child. So if you have to give IVIG to such a big child, it is an immunomodulatory dose of 1 gram per kg, which is extremely expensive and not so effective. So once we found the underlying diagnosis, we gave a drug which is super effective because it targeted the specific pathway. And we have also contributed to the world literature. This is the case series of 191 children with STAT3 gain of function disorder, and this child was part of this cohort. I would now like to invite Dr. Akshaya to present the second case.
Thank you, Dr. Vaishnavi. Am I audible?
Yes.
Okay, so this is another boy who is the firstborn of a non-consanguineous marriage. As you can see, he had a normal birth history. During the first year of life, he had recurrent diarrhea. After the first few months, up to 8 years of age, he had recurrent episodes of fever associated with cervical lymphadenopathy. And after 4 years of age, he had documented episodes of recurrent persistent lymphoproliferation, which included cervical, axillary lymphadenopathy, and hepatosplenomegaly. After 11 years of age, he had a 6-month history of a Henoch-Schönlein purpura-like rash, which was present on both his lower limbs, bilateral knee arthritis, and generalized lymphoproliferation. So for these symptoms, he was referred to a hemato-oncologist who got a lymph node biopsy done, which showed a lymphoproliferative lesion with intrafollicular T cell hyperplasia. So this child was started on steroids, to which he responded really well. And MMF was added as a steroid sparing agent, but they were not able to taper and stop the steroids. Hence, he was referred to us for further management and evaluation. Next slide, please. So at our center, we noticed that he had short stature, and this short stature was there throughout his childhood. He was evaluated at 5 years of age when his born age was around 3 years. He also had cervical and submandibular lymphadenopathy and a faint rash because the rash had reduced after starting steroids. His CBC was normal apart from his retic being a bit high. We screened him for other autoimmunities and noticed that his DCT was weakly positive. His TFT was deranged and he had very high titers of antithyroglobulin antibodies. So, as this child had lymphoproliferation with vasculitis, autoimmunity, short stature, so to rule out an inborn error of immunity causing immune dysregulation, we sent his NGS, which showed a heterozygous pathogenic mutation in STAT3. So this mutation has been reported to be associated with STAT3 gain of function in a child with short stature and multiple endocrinopathies. Next slide, please. So after the NGS report, we started this child on targeted therapy. Baricitinib was our drug of choice as it was readily, cheaply available at that period. He was started on baricitinib at 0.08 mg per kg per day in two divided doses, which he received for a total duration of 25 months at last follow-up. His lymphoproliferation disappeared within 4 weeks. He had no recurrence of his lesions or lymphadenopathy after the steroids were tapered and stopped. The steroids were stopped after 8 weeks of starting baricitinib, and 2 weeks after stopping the steroids, we were able to stop the MMF. His DCT turned negative 8 weeks after baricitinib. He did not have any infections or adverse reactions on baricitinib, and he had a significant gain in his height, as you can see here. So this case has also been published, and you can see it here. Next slide, please. So I would like to invite Dr. Vijaya Gauri ma'am to talk on static gain of function.
So, as we have already discussed, and as elicited by both Vaishnavi as well as Akshaya, both these children had actually presented with an autoimmunity. The first one with hematological autoimmunity, the second one with an arthritis, uh, a vasculitis like rash, which could have been a leukocytoclastic vasculitis. But by the time the child came to us and he had already received MMF and steroids, it was not in a position where we could biopsy it. So we did not biopsy it. So we couldn't prove a leukocytoclastic vasculitis there. He had an arthritis. He also had a hypothyroidism with an high antithyroid antibodies positive. Other autoimmunities were not elicitable. In all these patients who come with immune dysregulatory disorder, if we see one autoimmunity, we look for other autoimmunities as well. And many of these autoimmunities evolve over a period of time. So it is a practice for us to every 6 months re-evaluate them for any autoimmunity which would have come up, which was previously absent. So, and infections. No, none of these children, two of these children, they did not have any infection per se as a presenting feature, or they did not have it over a period of time, though lymphoproliferation was there, but infection per se and infection requiring admission or a prolonged antibiotic has not been reported in both our children. The other important thing is there is because of the gain of function STAT3, or when STAT3 gain of function occurs, there is increased phosphorylation of STAT3, and dimerization is increased, dephosphorylation. It gets dephosphorylated over a period of time, and that is also increased, as a result of which there is hyperactivity of STAT3. And this hyperactivity of STAT3, as already told by Vaishnavi and Akshaya, results in reduced phosphorylation of STAT5B. And STAT5B is downstream of growth hormone receptor, and therefore most of these children have postnatal short stature. So the moment you start them on JAK inhibitors, the growth retardation also gets reversed, as shown in both our children. And they have actually charted the growth. So this is very important. When these children are identified with STAT3 gain of function, and there is a STAT5B and STAT1 reduced phosphorylation, they are at increased risk of both viral and mycobacterial infection. STAT1 is very, very important for both viral and mycobacterial activity, antiviral and antimycobacterial activity. In the absence of STAT1 or reduced STAT1 phosphorylation, that is a risk, but it was not shown in our children. And while they were put on baricitinib also, we have not seen any of these infections because we keep screening them for all these infections. We do an IGRAS before we start them on JAK inhibitors. IGRAS was negative at the start of JAK inhibitor, and subsequently also when these children every 6 months we screen them from JAK inhibitors while they are on JAK inhibitors, and their IGRAS has remained negative. They have not shown any clinical signs of tuberculosis as well. Another important thing is we came across that they can be BK virus activation. So we have now started to screen them for BK virus as well, both in blood as well as in the urine. And that has also remained negative for most of both these children. And IL-6, as we saw, that is a primary cytokine that utilizes STAT3 for signal transduction. And therefore, when we know that what is the pathophysiological mechanism driving the disease process, we can actually use a targeted therapy. So we knew this is a hyperactivation and it is an IL-6 mediated process, and the IL-6 was high. So when we gave tocilizumab, platelets actually dramatically jumped in 24 hours. What was 2000 became 24,000, and in 36 hours 74,000. So this was a dramatic response which we could actually document, but then it was not sustained. It cannot be sustained because we know that there is a JAK-STAT pathway activation. We don't have something to block STAT, but we can always have a JAK inhibitor. Therefore, management was aimed to modulate STAT3 activity, and therefore we used a JAK inhibitor here. So both Akshaya has published this paper, and she has seen that when we use JAK inhibitors, there is increased risk of infection. There is decrease in type 1 interferon response, and there is increased viral infections and reactivation of herpes zoster. But as thankfully, both our children are doing well. The risk of opportunistic infection like bacterial pneumonia, as I said, BK virus induced nephropathy, toxoplasmosis, has been reported. We are evaluating them, screening them every 6 monthly, but it has not been there. JC virus induced progressive multifocal leukoencephalopathy has been reported in a patient on ruxolitinib. So far, everything is going fine. There is a risk of tuberculosis is very high because there is reduced STAT4 signaling and there is a reactivation of latent TB. But in these children, we screen them for latent TB, and so far there has been no MTB reactivation. Sparing of immune function relying on IL-1, IL-8, IL-17, TNF signaling through JAK independent pathway. The incidence of serious infection is low. JAK2 inhibition interferes with erythropoietin and thrombopoietin signaling and can cause anemia and thrombocytopenia, but it has been seen more with tofacitinib. Clinically, JAK1/2 inhibitor, ruxolitinib, usually has not shown this. I'm not saying that it may not come up, but it was more seen with tofacitinib, relatively sparingly with ruxolitinib. Hypertriglyceridemia also has been reported, but in our children, it has not been seen, probably because they are selective JAK1/2 inhibitor. Weight gain and increased BMI has not been seen in our children, but they are pretty young children, very active. That could be one of the reasons. And the leptin pathway inhibition also has not been seen in our children, but these are the side effects of JAK inhibitors. We keep it in our mind and we keep looking for it every time they visit us. So these are something which I would like Dr. Mukesh Desai to answer. Sir, I would like to know how long can we continue a JAK inhibitor? Potential long-term side effects of this drug, because it has been started since 2015. Of course, it was used for polycythemia vera, but here these kids are pretty young. Drug holiday did not help us in our children. The drug holiday did not help, but how are we going to go about it? Is transplant a good option? Yes, I know it's a financially feasible one, but only 62% is the survival rate in STAT3 gain of function post-transplant. Sir, I would like Dr. Mukesh Desai to answer these questions.
Friends, Vijay has given you a very good overview. Before I answer this question, I take the liberty of summarizing some of the clinical points which has emerged during presentation of these two cases. If you look at the first case when Vaishnavi presented, I think the patient was called as an extended Evans. Today, we believe that any patient who comes to you with an Evans syndrome needs an whole exome sequencing, because almost 65% to 67% of these patients have an underlying inborn error of immune deficiency. So I think this may be one very good takeaway point, that every Evans should be evaluated for underlying inborn error of immune deficiency. The second thing which I would like to say is that lymphoproliferation. Besides liver and spleen, spleen can be enlarged in patients of autoimmune hemolytic anemia. So that may not be a very good giveaway for lymphoproliferation. But say, for example, presence of lymphadenopathy, which was significant, would be a very important clue that this is not your routine type of autoimmune hemolytic anemia or idiopathic autoimmune hemolytic anemia. You need to evaluate them further. And in the lymph node biopsy, it might be feasible for an expert hematopathologist to look for double negative T cell population over there also. And immunohistochemistry would be very helpful. So if you have a histopathologist who can really pick up a double negative T cell population by doing immunohistochemistry, can actually pick up a patient of ours. So the lymph node biopsy would also be very important to look for an EBV signature. And more importantly, it's also to look for Hodgkin's lymphoma. So Hodgkin's sometimes you can have a picture which can be exactly confused, like an Hodgkin's lymphoma in patients who have chronic active EBV-like illness with underlying genetic susceptibility to them. And you should evaluate this patient for underlying inborn error of immune deficiency. I think Vaishnavi emphasized on the double negative T cell population. I think it would be important to tell everybody that we are talking about T cell receptor alpha beta double negative T cell. The gamma delta double negative T cell can be increased in various infections, including tuberculosis. So that is not important. The most important is T cell receptor alpha beta population. And in the Indian setting, we are taking up to 4% as something which is which is relevant in the Indian setup. The other important thing which I think for the double negative population is that the double negative population can be increased in many other conditions, like in germline TET2 mutation. In patients with X-Men disease, you can have a double negative population T cell receptor alpha beta, which can also be increased in such a situation. But the most important aspect about both these cases is that making a genetic diagnosis really gives you a clue as to how to treat them. And I think this was exemplified by Dr. Vijaya that tocilizumab worked wonders in the first patient where she told you the platelets from 2000 went to 24,000. And this is dramatic, where even steroid has not helped this patient. This was really a very dramatic response. Then next day it went on to become 72,000, and within a week it was 1,23,000. I mean, this is the power of making a correct diagnosis and then using the right molecule is really so visible. I think coming to JAK inhibition, I think they are the next wonder drug for a lot of immune regulatory disorder. When in the first patient, before I come to the JAK inhibition, when there was an ALS-like situation, you had an extended Evans and you had lymphadenopathy and hepatosplenomegaly. I think what important thing is that this was not like a classical ALS, because in classic ALS, you will see a bull's neck, which is very often the common presenting manifestation. Second thing is, whenever you have a suspicion of ALS or ALS-like illness, it would be worth doing the serum B12 level, the IL-10 level, and fast ligand if it is available with you, because these are biological markers which can tell you the presence of an ALS or a fast ligand deficiency. I think that was one another important point to make. Now, coming back to JAK inhibition, I think you can all see the dramatic response to JAK inhibition. And not only it improved the hemopoietic autoimmunity, but it also improved the lymphoproliferation, improved the height of the patient, and the molecular explanations are already very eloquently described by Dr. Vijaya. As far as we are concerned, for the time being, the children are doing so exceedingly well that we would like to continue JAK inhibition, giving them sometimes an intermittent holiday and see whether we can minimize the dosage. We would like to find out if we can give them lower dosage and still achieve the same result, because in the first patient we went on to become polycythemia. When this child developed polycythemia, we tried to reanalyze the exome. I think Dr. Vaishnavi reanalyzed the exome to see if there is any mutation in the EPO or EPO receptor gene, which could be responsible for the increased hemoglobin to the extent of becoming polycythemia. So this is something which we all looked at, but we couldn't find an explanation. And the moment that JAK inhibition was stopped, given a holiday, the patient had a drop in the hemoglobin. And so we do believe the STAT3 blockage was responsible for increasing the patient's hemoglobin value. The DCT had become negative by then. And this is in a patient who was already in autoimmune hemolytic anemia. So this was very dramatic difference, to the point that we had to do even bloodletting for this patient. Now, I would like to continue JAK inhibitor for a very long time. I don't know the long-term side effect of this drug. I don't think anybody has a good answer to that. But we all would look for viral infection, reactivation of tuberculosis, reactivation of viruses. The more we investigate, the more we will learn to find out what kind of side effect this patient develop. Obviously, drug holiday would be a good thing to do in this patient. It would also reduce your financial burden. And as in our first patient, when we gave a drug holiday, it took almost 2 to 3 months before the autoimmunity resurfaced. And so maybe we should be able to give intermittent drug holidays to this patient And yes, transplant, as more understanding improves of our immune dysregulatory disorders, it would be a good option. But remember, STAT3 is used by many other pathways, as we have learned from the haploinsufficiency or the Job syndrome, STAT3 loss of function. We know that STAT3 is required in many, many tissues, and it is not only the hemopoietic tissues. So you can cure the hemopoietic problem with an transplantation, but the non-hemopoietic issues, which we yet don't know about, will not be cured. I by doing only bone marrow transplantation. Financially, I think in today's time, it should be quite feasible to do a transplant. It might be even cheaper than using drugs like ruxolitinib and which are so expensive. As they are, as STAT3 is not a standard indication. Even your company doesn't give you the benefit of certain schemes which they have to give you the drug at a lower price. So I think these are some of the challenges which we will keep facing as these cases are few. As we collect more data, we will learn more about these diseases and start thinking in terms of them. And one important principle which we always follow, and I think Dr. Vaishnavi has done a study on that, that any autoimmunity, be more than one autoimmunity, look for an underlying inborn error of immune deficiency, and there would be a lot of molecular targets. Sirolimus might have been a good target to use in patient who has an ALF-like illness because they respond very well to that. So that was another option we had. But since we got the molecular diagnosis, we used the other drugs which were more specific to inhibition of the STAT3. So I think there are a lot of questions which come up. One other important thing is that a somatic STAT3 gain of function is responsible for large granular lymphocyte leukemia. But fortunately, till date, nobody in the world has yet seen a germline STAT3 mutation coming with a large granular lymphocyte leukemia like presentation. So we'll wait for it to emerge over a period of time as we observe this patient and monitor this patient more closely. We'll probably learn more about what kind of other aspects of the disease that emerge over a period of time. We are looking for endocrinopathies because that is another major problem that come with autoimmune endocrinopathies. So far, they have been doing quite well, and I hope. I think I have a feeling that the JAK inhibitor might be a little better than going for a transplant option because transplant option will only take care of the hemopoietic issue, but will not take care of the other autoimmune that the patient develops or the other issues which the patient may develop, which affect the other systems of the body. I think with this remarks, I'll hand it back to Dr. Vijaya.
Thank you, sir. So I would like to end the talk by acknowledging both the children and their families, the entire team of immunology at Wadia Children's Hospital, NIH for extending diagnostic support to some of these patients, and of course, my mentor, Dr. Mukesh Desai, for giving me this opportunity to present this case series. Thank you.
Thank you so much for this presentation. I'll hand it over to Joseph to take it forward.
Yeah. Thank you, Dr. Mukesh. Wonderful case. Thank you, Dr. Vaishnavi, Dr. Vijaya, Dr. Akshaya for that excellent discussion which we had. And, a few questions in my mind straight away. We have less time now. When we are faced with more than one immunodeficiency, it is good to do evaluation. At till what age would you suggest this evaluating for an underlying inborn error of immunity?
Well, Joseph, currently we feel that inborn error of immune deficiency can present at any age group. So if you give me the choice, I would do it for every patient who comes to us with multiple autoimmunity.
Okay, so that's great. With regard to evaluation for genetics, would you go for a whole exome sequencing, clinical exome sequencing, or a targeted panel for ALPS or any of those panels?
So I think this answer will be better answered by Vaishnavi. She is the one who is more interested in the genetic aspect. But I'll tell you in one line before I hand it over to her to answer this, that we don't do any targeted sequencing. We don't do any panel. We go for the whole exome. And Vaishnavi will elaborate on this.
So the newer disorders that are coming up, especially the immune dysregulatory disorders, they have quite a few genetic defects which can all not be covered in a targeted panel. So when the phenotype is very specific, for example, patients with SCID, in them, it may make sense to do a targeted panel. But by and far, at our institute, we prefer a whole exome sequencing. Now, when you talk about clinical exome sequencing, it is actually the same methodology is used. It's just that the bioinformatics team reduces it to the clinically relevant genes. But actually, the analysis, the entire processing of the sample is exactly like how you do for a whole exome sequencing. So at our institute, we do whole exome sequencing for all. In fact, recently, sir and us, we believe that whole genome sequencing is the next step, because many of these mutations are in the deeper intronic regions, or they may be in the promoter region, or they can be large copy neutral copy number variants which cannot be picked up in the whole exome sequencing. So once the prices for whole genome comes down, probably that will be the next best bet. As well as there are new methodologies where instead of using a single reference genome, people have started using pan genomes, which means that, which is good for us, because then even polymorphisms, which are polymorphisms for us, but in Western countries, since the frequency is lower, they are reported it as pathogenic variants. But once pangenomics comes in, even the polymorphisms, the local polymorphisms will be incorporated in the reference genome. And then instead of getting 50,000 or a lakh variants, it would come down to say 10,000 or 20,000 variants, even for whole genome sequencing. So that's the future. But currently, we prefer doing whole exome sequencing because simply the list of genes is too large.
Sure. So with regard to the doing the flow cytometry, sorry.
May I just add to this? I think when you ask for these exomes, like how the hematologist took over seeing the peripheral smear and bone marrows in the past, a time would come where I think people like Vaishnavi or Dr. Akshaya or Dr. Vijaya, who are clinical immunologists, will start looking at the exome themselves. They will pick up much more information than what the labs will pick up, because if you change one word, say for example, in a patient where you have written hypogammaglobulinemia, the lab will not even report a BTK abnormality because BTK will cause a gamma globulinemia. So that kind of errors will not happen. So I think time will come where the clinical geneticists will have to take over, or clinical immunologists will have to take over looking at the exome themselves.
Few more quick questions. So we will see some patients with all these symptoms there, but double negative is not there, and whole exome may come positive. Now, is there a possibility of a false negative double negativity?
We haven't seen anyone
Okay.
with false negative in a classic fast mutation, but
Okay.
in fast ligand you may sometimes have. But even in fast ligand heterozygous, we have.
So it has to be that, and a fresh sample, if it is done, you would get it. The other way around is clinical exome comes negative, but you clinically you think it is something to do with immune and inborn error of immunity. Is that a possibility? Is there a possibility that the clinical exome was missed, checking or missed, or a whole exome sequencing was missed, the mutation was missed, and clinically you have somebody with these symptoms?
It is very much possible that this could happen. This would happen in almost, say, 30 to 40% of our patients, where you are very certain that this is an inborn error of immune deficiency. We then subcategorize them into whether they are ALF-like, whether they have allergy, whether they have autoimmunity, whether they are IPEX-like, and then maybe even use a therapeutic drug, which we prefer to use in such a setting, and then go on to investigate them further to do a whole genome sequencing, as Dr. Vaishnavi already told you, and try and look for a monogenic defect. Plus, we must also keep in mind that not everything is yet discovered in inborn error of immune deficiency. There are more than 10,000 monogenic defects which are yet to be discovered. And I think we should go beyond and do the whole genome and start looking out for newer genes which may explain the patient clinical situation.
So it looks like ruxolitinib is the way forward, and you don't need to. Suppose you have an ALPS, you are not going to now say MMF. Maybe give steroids initially. Is there a way to give MMF to be given or not, or you go with ruxolitinib upfront?
So ALK-like situation, if you have fast ligand or fast mutation, the drug of choice is going to be sirolimus. It's a wonderful drug for ALK. For patient who have STAT3 gain of function, JAK2 inhibition either with ruxolitinib or baricitinib would be the way to go forward. And for immediate crisis, you can use tocilizumab, something like that, for rapidly increasing the platelet count if they are very low.
Would it be based on IL-6 or it is just based upon the clinical symptom?
It is not based on IL-6.
Okay. There's one question on baricitinib. Is that prone for thrombosis?
Thrombus, we haven't.
Thrombosis. No. Okay. So there's one more question in the chat box. Do adult patients with Ivan syndrome warrant exome sequencing as in children? What is the frequency of IEI in adult Ivans? I mean, similar to the what previous question we asked.
So Evans, absolutely, you must do in adults also, besides looking for lupus, and the chances of picking up may be less than what you may pick up in children, but it is still extremely high.
So all
And in
SLE
this,
essentially
this
will
entire
get
aspect, we have always been talking about monogenic defects, germline defects. We have not talked about somatic mutation. Just like how you have the Vexus syndrome with UBA1 gene affection, somatic mutation causing a Vexus syndrome, you would have a whole plethora of this autoimmunities who might have a somatic mutation in presenting in adults. We already know examples of ALS with somatic mutation. So this is an entire possibility which needs to be worked up. Henceforth, when we do an exome, we'll have to probably do it 500x or 1000x so that we can pick up somatic mutation.
Dr. Biju.
Yeah, fantastic presentation. So, Dr. Mukesh, just one question. So, if you take children who have autoimmunity, approximately what percentage will you find inborn errors of immunity? Will it be 20-30%? Will it be 50%? Or is it something which we still are exploring and we don't know?
So I'll answer that question, but I'll ask Vaishnavi. She did a study on this at our own institution. Roughly 50% plus some VUSs which clinically collaborate, but she'll tell you in detail. Vaishnavi, please.
Sir, this was part of my thesis when I was doing my fellowship still. So we evaluated all the children who presented with even a single autoimmunity. It took a lot of collaboration with many other subject specialties because most of them were going to other subject specialties. So even with a single autoimmunity, patients were evaluated. So a total of about 76 patients were evaluated, out of which we found autoimmunity in almost 50% of them. So 50% is a very big number, and these were proven likely pathogenic or pathogenic variants in a known inborn error of immunity gene. Of course, with a caveat that many of our patients had polyautoimmunity. So although the referral was asked for even a single autoimmunity, most of these patients had more than 2 or more autoimmunities. So that there was a referral bias also, because these were also patients who were refractory to common therapies that were given in their own parent departments. So in most of these patients, around 50%, we found an inborn error of immunity. There was no correlation with any abnormal immune evaluation or the response to therapy either. So we cannot say if the patient is refractory to therapy, there is higher chance of it being a monogenic cause. Or if there is a abnormal immune evaluation, only then we should investigate further for exome sequencing. So there was no such correlation found. And I also did not find any correlation between the number of autoimmunity and an underlying monogenic cause. So it also doesn't follow that if the patient has 3 or 4 autoimmunity, only then investigate. So our current strategy is to investigate all children with autoimmunity for an underlying inborn error of immunity.
So I think the take-home message should be all children with autoimmunity, we should evaluate for an inborn error. There's one more question. Joseph, you want to take that up?
No, you can. So I have a
Okay.
patient of PI3K delta with disseminated BCGosis. Responded excellently to sirolimus. Now 1 year post-sirolimus transplant or continue sirolimus? Yeah, good question.
Transplant.
So all PI3K deficiency, would you suggest transplant or?
Yes. PIK3 is a very complex situation, and it comes with multiple ways, and they have a lot of other complications, susceptibility to EBV, progression to Hodgkin's lymphoma, chronic active EBV. So all these patients ultimately succumb to their illness over a period of time, with or without therapy. Sometimes we may not get an opportunity even to treat them. A good drug would be leniolisib, which is being tried as a PI3 kinase inhibitor. But if you have PI3 kinase, if you can't have access to leniolisib, please transplant them.
I think there's one more question from Karthik. For SYK related autoimmunity, will sirolimus work?
You can use dasatinib if it is a gain of function mutation.
Okay.
Wow. So you're saying ruxolitinib, dasatinib, sirolimus, uh, tocilizumab, and tofacitinib. Is it being used? Tofacitinib?
Tofacitinib is more of a JAK3 inhibitor, so the association with immunosuppression is very severe. Then JAK3 is used by IL-2, IL-2 receptor. So, if I have a choice, I would use ruxolitinib over tofacitinib. Tofacitinib is available, you have generics available, it's cheap. But people must pay attention to the lymphopenia. You will lose patient to lymphopenia and patient developing viral infection, CMVs, and so you have to be very careful when using tofacitinib.
A lot more questions, sir. I wish we had a little more time. Maybe we should give them one more session to quickly come back and discuss because there's some, Pandora's box which all of us are dealing with but don't know. Okay, over to Dr. Biju to summarize the talk and then to
Thank
Deeksha.
you. So I think, I'm not going to summarize it. I think it went on very well. A fantastic discussion. It really actually opens up our eyes to looking at inborn errors of immunity in a different way because this raises up the whole question about autoimmune lymphoproliferation and how we manage that. So thank you so much, Dr. Mukesh, Vaishnavi, Dr. Vijaya, and Dr. Akshaya. It was a fantastic discussion that we had. I hope the people who are there, who participated, have learned a lot and have taken home the all the points which came out in terms of who we investigate, what are the drugs that we have available, how should we go about managing them. Over to you, Diksha.
Thank you so much, sir. So, thank you all for joining us for the episode 8 of Blood the Life Savior. On behalf of Intas Pharmaceuticals, I, Diksha Gehlot, extend my sincere thanks to Dr. Vaishnavi and Dr. Akshaya for presenting the case with clarity and precision. Dr. Vijaya Gauri for engaging and thought provoking discussions, and a special thanks to Dr. Mukesh Desai sir for his expert insights and a powerful concluding summary that brought the session full circle. We also remain deeply grateful to our course directors, Dr. Biju George and Dr. M. Joseph John, whose vision and consistent guidance continue to shape the success of this academic journey. Above all, our thanks goes to each one of you, our viewers and participants, for your time, presence, and dedication to this continuous learning. We look forward to welcoming you again for episode 9 with unique and relevant case. Till then, stay inspired, keep learning. Good evening, and thank you once again.